Next talk is
Thank
by
you.
Dr. Dushyant Khedikar. Topic is immunotherapy in allergic rhinitis and nasal polyps.
The allergens are nothing but our normally occurring substances in the environment. Lot many people tolerate them, but approximately 30% of the patients or 30% of the people do not tolerate them. Their immune system considers this thing as some foreign substances, and it starts responding in the form of type 1 hypersensitivity. So what goes wrong with this patient is that now every single individual is having an TH subsets, TH1, TH2, then TH9, 27, and all these TH subsets. Even the T regulatory cells are there in the immune systems. But in the people who have genetic predispositions or where the barrier functions are not good, and when the allergen exposure is continuous, there is a clonal switch to the B cells which stimulates or which increases the TH2 populations, also to a certain extent TH1 populations. That leads to the type 1 hypersensitivity. So all the cytokines, vasoactive amines, proteases, and the late phase reactants like prostaglandins and leukotrienes, they will cause the early phase symptoms and the late phase symptoms. So till the time the pharmacotherapy has its own role in the treatment of allergic rhinitis. To a certain extent, surgery has some role in relieving the nasal obstructions whenever there is a deviated septum or polyps. But if we are targeting for a long-term cure, then it is necessary that there has to be either the allergen has to be avoided. If it is possible to be avoided allergen, then it will be the wonderful thing. So without spending much of the money, you can still control the allergy, but that is not possible in every possible cases. So for the cases where the allergen is non-avoidable, kind of an aeroallergens, allergen-specific immunotherapy has a significant role in modifying the diseases. Yeah. So the role of immunotherapy is to establish a long-term clinical tolerance against the allergens by changing the memory type allergen-specific T and B cell responses and increase in mast cell and basophil eosinophil activation thresholds. Yeah. So what happens in an allergen immunotherapy is that the clonal proliferation, which was more deviated towards TH1 and TH2 cells, predominantly the TH2 cells, it shifts towards the T regulatory cells. Now, there are certain responses which happens early in the phase of the allergen immunotherapy, like preventing the degranulation of the basophils and eosinophils and the mast cells, thereby relieving the allergy symptoms in early phase. Now, this particular phenomenon is observed as early as 2 to 3 months of the therapy, in particular in sublingual immunotherapy. Even subcutaneous immunotherapy, this will be observed much earlier compared to sublingual immunotherapy. In the later phase, or as the immunotherapy progresses, the IgG4 counts will keep on increasing. Now, IgG4 counts, they have a very important role in preventing the allergen to bind to the IgE molecule. So what happens is that there is a loss of signal to the clonal cells, the naive T cells, which increases the IgE proliferation, and that's why the IgE will slowly start coming down over a period of time. But this is a late response. It can be seen very later in the phases of immunotherapy. Even after completion of the immunotherapy, sometimes it is possible that the IgE can still be higher level, though the patient's symptoms are controlled. Over a period of time, because now the inflammatory markers are coming down, the serotonin, the histamine, all the prostaglandins and all these things are coming down, there starts a tissue remodeling. Okay, now this tissue remodeling is primarily because of the release of tumor growth factors beta, blocking of tumor growth factor beta, and the cellular inflammation which was there because of the allergy, now it starts recovering back. There, the smooth muscle expressions, the vascular spasm, the bronchial spasm, it starts recovering. And that's why in most of the times what we see in allergen immunotherapy is that the nasal sinus symptoms, they respond faster compared to the lower respiratory tract symptoms. Yeah, so we'll go to this side. So, fine. So, what happens when an allergen enters on a normal person and when it when the same allergen, it is when a person on immunotherapy, he receives the same allergen. So there are some different phenomena or different changes which keep on happening. So in normal healthy individuals, at a very low doses, there is no T cell proliferation or cytokine releases, and there is no sensitization. At lower doses, there is Th0 responses, the specific T cell clones with lower frequencies, there are very specific T cell clones, so it is a normal phenomenon. At higher doses, there is increase in Th1 population, particularly the interleukin 10. Now, interleukin 10 is related to the productions of IgG4 molecules. So, this will help in protecting the person against the allergen. Now, what happens when the same allergen enters in a genetically predisposed person who is having an allergic tendency is that there is a clonal proliferation Th2 cells. Now, these Th2 cells will increase the interleukin 4, 5 and 13. However, the Th10 and interferon gamma population decreases. So, this increase, all these things will lead to tissue inflammation, increased permeability of the tissues, the chances of polysensitization, and if it continues over a period of time, then definitely the polyp formation and other things. Whereas in allergen specific immunotherapy, decreased allergen, it decreases the T cell proliferation of Th1 and Th2 cytokines. Now Th1, it is very important. Now Th1, we think that there is a switch from Th, in allergen immunotherapy, there is a switch from Th2 to Th1. It is not like that. Even the Th1 cells are responsible for epithelial apoptosis. Now this epithelial apoptosis will reduce the barrier functions of the epithelium, thereby promoting the polysensitization phenomenon. The major benefit of allergen immunotherapy is induction and increased suppression by the T regulatory cells. Now, once we start immunotherapy, there will be certain antibodies which will be increased during this immunotherapy. So, in the if immunotherapy is given in a healthy and non-allergic individuals, so there won't be any because they are not sensitized. There won't be at a lower doses. There won't be any detectable antibodies. Whereas at higher doses, if the allergen enters the body, it produces the IgG4 antibodies, IgG1, IgA, as well as IgE antibodies to a certain extent, but predominantly IgG4 antibodies, which are supposed to be protective. Whereas an allergen, if a person is an allergic individual, not receiving an immunotherapy, there will be relatively high IgE antibodies, and the IgG1 and IgG4 or IgA antibodies will be very less, whereas in the person who is receiving an immunotherapy, the specific IgG4 antibodies will increase, and very lately there will be decrease in the IgE molecules. Fine. So T regulatory cell contributes. So I think we have already seen this thing, so we'll skip this thing. Yeah. So types of immunotherapy. Classically, we know subcutaneous immunotherapy and sublingual immunotherapy. Because of the safety profile and logistically, now the sublingual immunotherapy is very much preferred. But in India, we have the options of giving the allergen extracts in the drops form, which help us to titrate the doses better compared to the tablet forms. There is a peptide immunotherapy. Now, it uses the synthetic peptides to induce allergen tolerances. This is still in research thing, not very commonly used. Atopic dermatitis, few of the patients of atopic dermatitis has been tried. Yeah, so this, I think we have talked about this thing. Now, what we have seen is that on the nasal polyposis thing, now I have 3 scans over here. The first 2 scans are of a same patients. One is before start of allergen immunotherapy and one is 2 years after starting of allergen immunotherapy. What we can see is that though there is a change of inflammatory pattern over the scans, there is not complete resolution of the polypodal thickening. It is predominantly the ethmoid thickening, and whatever we can see in the maxillary sinus is the retroobstructive changes. So, though the patient, the inferior terminate volumes are reduced and the patient is able to breathe properly, still the inflammatory disease in the form of polyps is still there. The third scan, I don't have a pre-operative scan of, unfortunately the patient lost that scan. So, I have the post-operative scan of this patient. Again, this scan was taken 2 years after the sublingual immunotherapy. What we can see is that after the disease clearances, the sinuses are pretty much healthier. There is not much of the mucosal thickening and it looks better, and symptomatic wise also the patient was better. So, from our data, we have around 89 patients who has completed 2 years follow-up for allergen immunotherapy. What we can say is that the nasal symptoms and the breathing improves in the patients with allergen immunotherapy with time. Maybe these patients, as a bridge, they will require the pharmacotherapy in early phases. The symptoms are fewer, the nasal congestion decreases over a period of time, seasonal exacerbation decreases. Polyp do not show significant changes. There were 22 patients what we included in this particular observation. They require the surgical care, but what problem they go after the surgery is that though the allergy symptoms are decreased, the sinusitis, acute sinus infections, whenever they occur, they take a long time to resolve. Thank you.
Thank you, sir.
Dr. Dushyant.
Now I request our chairpersons to felicitate Dr. Rupali Jain, Dr. Prashant Kevle, Dr. Vikram Khanna, Dr. Makarand Damle, and Dr. Dushyant Khedikar, sir.